clotting to occur all the time. And so we have factors that limit clotting, and then we also have factors that remove the clot once it's formed. So, can I move to the next slide now? Okay.
Thank you.
So on the next slide, she wants the page number.
647.
Thank you.
So on the next slide are some chemicals, both or factors, both already in the body or artificial ones that we can add to the body that limit clot formation. So there's a typical normal platelet repulsion. The platelets don't normally stick to each other. That has to be inhibited, or the platelet activation to allow them to attach to each other by that von Willebrand factor. Dilution of clotting factors. So again, a good blood flow. So platelets settle down. The clotting factors settle down too and become high in concentration. On the contrast, if the clotting factors are too diluted, then you can't form a clot when you need to. So there is I think some of you might be doing, anyone here doing the leukemia case study? All right, in that the case study, it talks about disseminated intravascular clotting disorder. And I used to give a case study on that condition alone, based on a patient of mine. So just before I moved back out to California to start my doctoral program at Davis, I was working labor and delivery in Maryland, and I had a patient who, along with her husband, had been trying for a little over 10 years to get pregnant. And they finally had become pregnant, and their baby was, she had a doctor's appointment on its due date. And so she and her husband went to the doctor's office, and they were unable to hear a baby's heartbeat or see it on the ultrasound. So the OBGYN sent her to the hospital, and they weren't able to find the baby's heartbeat there either, and the baby had died in utero. Well, it was the baby's due date. The parents knew the baby had died. The doctor knew the baby had died, and they both wanted to do a cesarean section and just take the baby out. And they were preparing to do that. When the other physicians said, you know, you really don't have a medical reason to do a C-section. Yes, psychologically, it might be better for the parents, but this is a major surgery, and you're putting the mother at risk, and you shouldn't be doing this. So the doctor backed off, and you can't just induce labor. You could rupture the uterus because the cervix wasn't ready yet. So they started giving the mother prostaglandins to soften the cervix and prepare her for labor. And the prostaglandins got her body temperature very elevated, over 104, which can cause convulsions. So they put her on an ice blanket, and it was just one problem after the other. And then about 3.5, 4 days later, she went into labor. The doctor wasn't there, so another nurse and I delivered the baby. And he was, except for the fact that he had died, he was a perfect little boy. There was no cord wrapped around the neck. There was nothing on the surface that would indicate why he had died. I don't know if it was a transfusion, erythroblastosis fetalis, or what it was. But, sorry, I'm so emotional about it. They took the mother back to labor and delivery, because of course the placenta and afterbirth and everything had to be delivered, and I stayed with the dad. And the mother was in OR for over 6 hours. Her blood would not clot. They gave her about 10 units of blood. You only have 5 in your body. And she had disseminated intravascular clotting disorder as a result of the baby having died. Even though the baby didn't have any decayed tissue, all right, chemicals released from the dead tissue could have triggered it. It could have been the prostaglandins that triggered it. But what occurs in disseminated intravascular clotting disorder is tiny, tiny, tiny little clots throughout the body. Not a big, massive clot, but tiny, tiny, tiny little ones throughout all the little arterioles. Not all of them, but through many of them. And so she had too many clots forming. And yet, she almost bled to death. So how does that happen? How can you almost bleed to death from having too many clots form?
Isn't there some kind of negative feedback from the limiting factors here?
Essentially, she had so many clots forming that it used up the clotting factors. So the clots that had formed had taken the clot, had
They were too small to actually do what they were designed to do.
well, they hadn't caused a medical problem because it wasn't every little blood vessel that was blocked. It wasn't a big enough one to become a problem if they broke free. But in doing so, it had used up enough of her clotting factors, and she didn't have time to make more, that at the side of the uterus, where the stratum functionalis was separating from the stratum bassalis, or the decidua was separating from the stratum bassalis, there was nothing there to trigger the clot. And so there's another situation in California having to do with this dilution. A woman went in for liposuction. It was a outpatient who went to the doctor's clinic. She'd been there for one visit before. Her husband dropped her off mid-morning, said, "I'll be back to pick you up around 3 o'clock or so." And he didn't hear from her, so he called, and they said, "Well, she's still in the procedure room." And he didn't hear her, he didn't hear her. So finally about 5 o'clock, he drove over there. And what they hadn't been willing to admit to him over the phone was that she was in an emergency critical condition. The physician doing the procedure had, and I don't know if you know, procedures have changed slightly, but it's essentially a long cannula with a cutting blade. And they slide it back and forth, and it cuts the adipose tissue, and essentially whizzes it up, and a vacuum draws it out.
Cuts off the capillary.
But he had cut blood vessels. And so many that her blood pressure was dropping with the loss of blood. Instead of stopping and replacing the blood, he continued. She continued to lose blood, so they increased the IV to replace the blood volume, and that temporarily brought her blood volume up. But as she continued to lose blood and they're replacing that with intravenous fluid, they weren't replacing blood cells for oxygen transport, and they weren't replacing clotting factors. So they eventually reached a point of no return where they couldn't stop the bleeding because there was insufficient material, and she ended up dying at the clinic because the staff wasn't willing to admit early enough that they'd gone too far. So normally dilution of clotting factors is a good thing, all right, but it can become a problem when clotting needs to occur. Antithrombin-3 is a factor that is produced by the body. It blocks the activation of thrombin. It blocks the interaction between prothrombinase and thrombin. And we have the rest of these are all medications. Heparin C and Coumadin are two forms of anticoagulants that are commonly used in people that have a history of forming clots.
Or after surgery.
Well, heparin C is an intravenous form. So let's say you need antibiotics twice a day that are given intravenously, there's no need to walk around with an IV bag or even stay in the hospital if that's all you need it for. So many times they'll put in a heparin lock, they'll put in an intravenous needle that has a rubber diaphragm on the end, tape it in place. And then when you need the medication, they give it to you into the IV through that needle without having to be hooked up to an IV pole the entire time. You don't need the fluids. And so before and after the medication, they'll push a heparin solution to keep blood from blocking the needle. Also, my husband and I have a friend who was in an automobile accident 24 years ago. His coming up 99 in the fog, and looked behind him and saw a car coming really, really fast and realized the car was going to hit him. So he still regrets to this day doing so, but he decided to move over. And he hadn't quite moved over by the time the car hit him, so it hit the corner. the backside sent him sideways and into a Caltrans truck that was working on the sound wall along 99. He feels that if he allowed the car to hit him from the back, he would have just been sent forward instead of scooting across. He ended up breaking his pelvis. He was in the hospital for 3 weeks. Pelvis area, fractures of the pelvis are highly conducive to clot formation. There's a release of lipids, and that can cause blockage in blood vessels. He was sent home without the warning, apparently, from what he and his wife said, that this could be a problem. And the next morning, he woke up with chest pain. So his wife took him right back to the hospital, and he had formed a clot that had traveled to his lung. So they put him on intravenous heparin for a couple of weeks while he was in the hospital, and now this is 89. He still takes Coumadin, which is an oral medication, every day. They have different effects. Coumadin and prevents the vitamin K's role in the liver. Streptokinase, or an alternate form TPA, is often given at heart attacks or strokes. From 430, we had a case study last semester, and the question was, should, the guy had had a cerebral vascular accident, and the question was, should he be given TPA? And what needed to be discovered was whether the cause was a ruptured blood vessel or a clot. TPA would be fine for a clot, but you don't want to decrease bleeding time if you have a ruptured blood vessel. All that's going to do is cause more blood to leak into the brain tissue. So this is often used to break down clots in the brain or in the heart. Here's aspirin. Okay, it inhibits the platelet component of thromboxane. And then we talked about the prostacyclins on the endothelial cells. I think you have this in a table in your lecture notes.
Page 30.
Okay. Clots, once they are formed, we want to break them down. Okay. So I want you to recognize that the molecule that breaks down clots is called plasmin. Its inactive form is plasminogen. That sounds very similar to thromboplastin or tissue thromboplastin. Remember, that's our activator for the extrinsic pathway. Plasmin is going to cause removal. It's going to enzymatically cleave the fibrin threads. So those two have opposite results. Tissue thromboplastin is going to result in the formation of fibrin threads. Plasmin is going to result in the loss of plasmin threads. So your body balances, hopefully, this so that it occurs only when needed. Okay, let's look at some disorders. Anybody still need that slide? I don't mind bringing it up. Let's look at some disorders. We've mentioned deep vein thrombosis. All right. So a thrombus is a clot. An embolus is a piece or the entire clot that is moving. Okay, so it's mobile. But it doesn't have to be just a clot. You can have an air embolism. You can have a lipid embolism. It's whatever's going to block the blood flow that's moving through a blood vessel. So typically a clot will form in the lower extremities and move up into the heart, or through the heart to the lungs, or it may actually form in the heart itself.
When I have surgery, I'm going to inject myself with heparin so I wouldn't get blood clots.
The clots and stuff.
I hate
So in a deep vein thrombosis, in the formation because of stases and the settling of blood cells in the lower extremities, that's the most common location of deep vein thrombosis. I didn't know the woman, but I knew her daughter. She developed a deep clot between this long. It went from her thigh up to her external iliac. And obviously she was hospitalized and put on heparin. And I was like, well, I asked, but they didn't know. I would have assumed they would have wanted to put a stent in between the clot and the heart, so if any pieces broke off, they wouldn't move on to the heart. Signs and symptoms of deep vein thrombosis is heat and pain on dorsiflexion, because that compresses the deep veins more. And so you never want to give someone, when I was in nurses training and I worked the 3 to 11 shift, we would go to our patient's room and offer them a massage. I don't think nurses have had time to do that for years. And I've been groped by guys I've been giving massages to, so I quit doing that too. You would never want to give a massage and push, massage the lower extremities towards the heart at the risk of breaking off a clot on someone that has a history of DVTs. Okay, thrombocytopenia. Cytopenia refers to too few cells, and in this case, it's not enough platelets. And so when there is tissue damage or small capillary breaks, and the blood leaks out into the tissues, there's nothing there to block that small arteriole, like a typical platelet plug might do, other than the vascular spasm. And so there ends up being lots of little collections of blood under the skin, purpura. We actually have one of our faculty members has thrombocytopenia, so you have to be careful with bruising. Doesn't mean the blood won't clot, but you have a component of enhancement of that clot that is missing. Hemophilia? Yes.
Is that what they consider like a strawberry patch also, when babies are born?
No, that's a vascular, additional blood vessels.
Does it eventually fade away?
Yes. The blood will be removed. Hemophilias are not a platelet problem, but a clotting problem. This is factor 8 that is missing. It's part of the intrinsic pathway. Most of you are aware this is linked to the royal czars of Russia, from which it became famous. It's carried by women, but shows it can be in a woman. Okay, usually women are carriers. It's a recessive sex linked, and so it means the woman is protected by having a normal gene on the other X chromosome, where the male does not. But if the woman has 2 affected X chromosomes, she can also develop the disease. So a guy who has the abnormal gene, missing the gene for the factor 8 on 1 chromosome, and then has the Y chromosome, is going to be missing, and they're not going to have synthesized the factor 8. So it's primarily in men, but it can also be in women. And extensive easy bruising, all right? So it's the clotting factor 8, so they have a problem with the intrinsic pathway for this to occur. And in the early history of AIDS, a lot of hemophiliacs were infected with AIDS because they require extensive transfusions of clotting factors, of the plasma with the clotting factors. And so before they started testing for that, they became infected by a lot of that blood.
So did he hit one part of his body and then it just spread almost?
No, it could be multiple.
Oh, okay.
Because a lot of times we have small breakages all the time of the capillaries in our body from bumping into walls or pressure from sitting a long period of time or whatever, and those are just
Because I was going to ask if it
easily.
spread, did it hurt
It can,
all over?
it can, and some of that, but it's not like a hamstring tear
Right.
where, you can get a huge collection of blood behind the knee. So this is probably a combination of both.
If it did spread, would it hurt in the places that it spread as well, or just
But
if
it's
it's
this pressure, yeah, if you get the swelling. The pain is often due from the additional fluid and pressure. Okay, so let's move to, we forgot about, I thought we have less time than we did in the morning, and I spent time going over some of the clotting problems with them. I did a few yesterday. So let's move to lymphatic circulation. I did change the quizzes, the next 2 quizzes So if you go online, there's a quiz that closed tonight. And then the next quiz as well I changed. So,
So it doesn't close out?
it doesn't close tonight.
Okay.
I don't remember what day I changed it to, but the new date is on
The
the
19th.
19th, that's Tuesday night. Okay, and what?
The 22nd.
22nd, okay. We're due to have a lab quiz on Tuesday, which would probably be the blood cells and lymphatic tissues. And I'm gonna move that to Thursday, because we're doing that lab for the first time on Tuesday,
Thank you.
rather than part of it yesterday and part of it Tuesday. Okay, eventually I think we'll catch up. Anyway, so let's come back to the source of the lymphatic fluid that the lymphatic system is involved with. Yesterday I talked about the hydrostatic pressure and osmotic pressure, and the fact that we lose tissue fluid out of the capillaries because hydrostatic pressure is higher on this end, and osmotic pressure will pull some of that tissue fluid back into the venous end of the capillaries, but not all of it. And to maintain our fluid balance, we need to return that fluid to the cardiovascular system. And so the lymphatic system is set up to do just that. We have lymphatic capillaries in the same location that we have blood capillaries. But notice that the blood capillaries are closed. They're connected to arterioles and venules at each end, whereas the lymphatic capillaries are blind-ending, and even though they look closed, they are actually open. So lymphatic capillaries have an origin, and they are formed of endothelial cells, simple squamous epithelial cells, that under increased tissue fluid, so the additional fluid moves into the tissues, it actually spreads apart these epithelial cells. And so there are fibers that are attached to the cells, and that increased pressure actually works on those fibers, and so the space is increased, and that excess fluid flows into the capillaries. Yes?
So, like in your legs, if your feet swell up,
Mm-hmm.
and if you use your legs, the muscles act like something.
Correct. I'll help to increase that. Not only, yes,
You said lined with simple squamous, right?
yes.
Okay.
Not only does fluid, water, go in there and associated proteins, but any cells that are in that area will enter in as well. So white blood cells will go into the lymphatic capillaries. Red blood cells do not. So we don't find red blood cells in lymphatics, because our red blood cells, unless there's a bleed, aren't in the connective tissue. So tumor cells are metastasized. In addition to that, any pathogens, because these function best in loose irregular connective tissue, and loose irregular connective tissue is what we find deep to in the epithelia. So in your nasal passageways, in your digestive passageways, in your lungs, this is that's where we find viruses and bacteria passing across our epithelium. And so these can also enter into the lymphatic tissue.
What about the basement membrane? Is there a basement membrane for these?
It's discontinuous. I mean, there's
Oh,
it passes, but it's
Okay,
not.
so that's why I was
Yeah,
asking.
it's not completely
Just
present.
confused.
All right, so now the fluid, and we have a specialized lymphatic capillary present in the villi of the intestines. You'll see this in lab on Tuesday. So the intestinal surface is thrown into folds covered with simple squamous epithelia. And we have a single lymphatic identified as a lacteal. Remember when we talked about the portal system? I said that the portal vein is transporting amino acids and simple sugars to the liver. What are our three organic fuel sources? Building blocks.
Proteins.
And
carbohydrates.
Fats.
Lipids, proteins, carbohydrates.
So the lipids are not in the portal vein, the absorbed lipids. There will be a small amount, but not the absorbed ones. The lipids are packaged. You've heard of LDL and VLDL. And that is too large a protein to move into the blood, too large a structure to move into the blood molecule. And so these lipids with their protein coat enter into the lacteal. and along with lymphatic fluid are transferred back to the cardiovascular system first. And so it's our hepatic artery that has these lipids going into the liver. So the portal vein has the amino acids and simple sugars. The hepatic artery has the oxygen and lipids. And we have those two components. So let's look at the last few minutes that we have here.
It's packaged within the lacteals, you know?
Well, the package is occurring in the columnar cells. And then exocytosis sends it out of the intestinal cells and into the lacteal. So here's an image of the major lymphatic vessels. And when you look at it, they have valves just like veins do. And scattered along the lymphatics are lymph nodes. So on Tuesday, we're going to talk about lymphatic tissue. We're going to see lymphocytes and macrophages, first of all, are arranged around the lymphatic capillaries in a loose arrangement, just scattered cells. But they can also be aggregated into tight spheres. And then we put those spheres of lymphocytes within a capsule, and that's a lymph node. Most of you have probably felt on yourself a swollen lymph node. So if you had a sore throat, you may have had a swollen lymph node along the jawline or down the neck. You may have at times felt a swollen lymph node in your axillary area. And so those are lymph nodes that have been processing lymphatic fluid that found something that lymphocytes recognized and they multiplied in order to destroy it. And that's the purpose of this whole system is we don't want this tissue fluid being dumped into the blood, which is sterile, and we're adding all these viruses and pathogens without filtering it first. So the tissue we'll talk about on Tuesday is a series of filtrations that the fluid passes through. And then it enters into these lymphatics, which then use one of two different ducts to empty the blood back into the cardiovascular system. And this is an asymmetrical pathway. So we have the lower extremity and the left side of the body. And then the left side of the upper extremity using two different systems. So the lower extremity and the left abdomen and left side of the body are going to drain into a dilated chamber known as the cisterna caudate. This dilated chamber narrows, and the duct that forms, it's a screen vessel right here found between the azygous and hemiazygous vessels, carrying lymphatic fluid, rich in lipids, and all the rest of the lymphatic tissue fluid. It goes up and empties into the jugular vein just between the external and internal jugulars. And down here, yes. So it's emptying in right here. So the left side, that's the left side. The right side has a very short, about an inch or so long duct that empties the right upper extremity, right chest, and right head. So this is known as the thoracic duct. One of those four birds, the goose, azygos, and hemiazygos. This is the thoracic duct. And this is the right. They're not. So if someone has a mastectomy and a radical mastectomy, which is not just the removal of the tumor or part of the breast tissue, but the entire breast tissue and surrounding lymph nodes, because the tail of the breast drains via those axillary lymph nodes. So they'll remove the axillary lymph nodes, and the woman will have trouble with a swollen right arm or left arm, depending on the side of the surgery, for several months afterward, because that system for returning excess fluid back to the cardiovascular system is absent. And she will develop additional lymphatics, all right, but it takes a while. There is, and we'll finish with this, there is a condition of parasitic infection. Which shows some really weird pictures. In the male, there's scrotal sac, can be this, I mean, sitting on a chair, it'll reach the floor. Or they have lower extremities that are the size of elephant legs, because the parasite gets into the lymph node and multiplies and blocks the passage of fluid through the lymph node. All right, we'll stop there. On Tuesday, we'll start with the tissues. So we'll start with diffuse and then nodules and nodes and talk about their function on the beginning of Tuesday. We'll do our blood lab and immune system organ lab on that day. Take a little bit of time, if you will, over the weekend to familiarize yourself with the structure of those tissues, especially lymph nodes, because there's so many little cells and fibers in there that the pathway can be confusing for students when they look at it in the microscope slide. So lab will go a little easier if you just take a look at that before you get to lab on Tuesday. Have a good weekend. I'll have your exams graded and posted before we come back to class.